Well, there have been a number of studies, several of which I'm the PI on, showing that if a patient fails ipilimumab and then there's an interval of time, usually 8 to 12 weeks, the response rate to PD-1 antibodies can be quite respectable, around 30%, PD-1 or PD-L1 antibodies. And the survival shows a median in the range of 18-20 months, which is again quite respectable. However, in the 064 BMS study, which was a forced sequence study, a forced switch, where you either give nivolumab for 12 weeks, ipilimumab for 12 weeks, then nivo maintenance, or the inverse, meaning you start with ipi for 12 weeks, then go to nivolumab for 12 weeks, and then you go to nivo maintenance. There is a very significant difference, or an impressive difference in response rate, 42% versus 20% at week 25. Best overall response rate, 53% versus 30.8%. And the survivals were significantly different, even though survival was not the primary endpoint of the study, favoring nivo-ipi. So I would not go ipi-nivo at all. I think the lesson of that randomized phase 2 trial, even though you can argue about the demographic imbalances, even though you can argue it was a modest-sized phase 2 study, not a phase 3 study, they're not definitive data, looking at the response rate, the overall survival, and the toxicities, which were fairly close and significant, I would not go with ipilimumab frontline. I would always go with the PD-1 or PD-L1 antibody in melanoma first, and then if they failed, then I would use ipi. Obviously, if a patient has an aggressive malignancy, high disease burden, high LDH, in the US, most of those patients are getting ipi plus nivo. In Europe and Australia, it's not as easy to use ipi plus nivo. I do not think that regimen is approved, so those investigators will use the combination on a trial. The argument in our field, of course, is for an indolent, low disease burden patient who's BRAF wild type, should you use single agent PD-1, PD-L1 antibody first and then go to ipi? That's a possibility, but I surely would not go the opposite. I would not use ipilimumab up front. I think it is now a second-line drug or a drug used in combination with other checkpoints.